everybody's in. You're good to go.
Awesome. All right. Good evening, everyone. My name's Christina Cruz, and I'm a nurse practitioner. I work with the UMass Renal Division, and this evening I'm going to be reviewing anemia management in the ESRD population. And I actually brought a friend with me. His name's Giacomo, and he's going to be with us throughout this PowerPoint presentation. Giacomo, say hi. All right. Okay, so our blood is very fascinating. It provides nutrients to cells, removes waste products, fights infection, and helps regulate temperature and pH balance. Blood, as you know, is composed of plasma, platelets, white blood cells, and RBCs. And today we are going to be focusing on the red blood cell. Our organs would not be able to function without these microcells. They're made for gas exchange. They carry oxygen to our organs and carry carbon dioxide to the lungs for expulsion. Their tiny size of 6 to 8 micrometers in diameter allows them to fit through our tiny veins and arteries. Additionally, they have a biconcave dish shape and no nuclei, which gives larger surface area to carry more gas molecules. The average lifespan of an RBC is about 120 days. So I found this picture online and I like it because it shows the relative size of a red blood cell compared to other molecules, some very microscopic that you wouldn't be able to see with the naked eye. And you can see here it says the red blood cell is 7 to 8 micrometers compared to a grain of pollen right above it, 15 micrometers. If you go down, you can see the coronavirus down near the bottom, very tiny. And the smallest one is the Zika virus, which is 0.943 micrometers in diameter. So very small, but kind of a cool chart to look at. So how are red blood cells formed? So this is the anemia feedback loop or erythropoiesis. And as you can see, hypoxia is going to stimulate the kidney to create erythropoietin or EPO. And then the EPO stimulates the bone marrow to create the red blood cells, and that increases our oxygen. So Giacomo is going to give me the thumbs up because he knows that I'm nervous. And Giacomo, do you have anything else to add? What does he want to say? Did you know erythropoiesis is a Greek word that means the making of things? Actually, I did not know that before this, so thank you. What is erythropoietin? Erythropoietin is an essential hormone that regulates the production of red blood cells and ensures adequate oxygen delivery to the body, as we saw on the previous schematic. Hypoxia is a stimulus for the synthesis of erythropoietin or EPO, primarily by the kidneys. Specifically, it is secreted by the peritubular interstitial fibroblasts in the renal cortex. In fetal development, the liver, brain, spleen, and lungs also produce erythropoietin. So what is anemia? Anemia, as defined by the World Health Organization, is hemoglobin less than 13 in men and hemoglobin less than 12 in women. Causes of anemia can be acute or chronic. Chronic can include medication-related side effects, such as with antineoplastics or PPIs, nutritional deficiencies, inherited genetic defects, insufficient RBC production, like in Fanconi syndrome or thalassemia, RBC destruction, like hemolytic anemias, or chronic diseases such as rheumatoid arthritis, systemic lupus erythematosus, liver disease, or kidney disease, just to name a few. In this presentation, we will focus on anemia of chronic disease, specifically pertaining to ESRD. I did want to touch on some red blood cell morphology, particularly focusing on the mean corpuscular volume. There's more detail that goes into categorizing red blood cells by size, color, and shape. This categorizing can help determine the type of blood disorder a patient may have. Microcytic anemia is smaller than normal red blood cells, such as iron deficiency anemia, thalassemia, or sideroblastic anemia. And sideroblastic is when the bone marrow produces ringed sideroblasts instead of healthy red cells. And this can be genetic or acquired. Normocytic is, as it sounds, normal-sized RBCs and can include aplastic anemia, which is a rare bone marrow failure disorder, not producing enough blood cells. Also includes anemia of CKD and sickle cell. Macrocytic anemia, like it sounds, larger than normal RBCs and includes pernicious anemia, which is impaired intrinsic factors secreted by the stomach, so the body doesn't absorb enough B12. Also includes folate deficiency. This slide represents the three major reasons that there's anemia in ESRD. ESA production is reduced. Additionally, the lifespan of RBCs is said to be decreased by 20%, secondary to the toxic or uremic environment in ESRD. Blood loss in the extracorporeal circuit by way of clotting the system or hemolysis, by resistance or obstruction of blood flow through the circuit, kinked tubing, or excessive blood flow through small gauge needles can cause blood loss during hemodialysis. Iron deficiency anemia includes both IDA and functional IDA, which we will discuss more on the next slide. Iron deficiency anemia. A healthy diet generally will yield enough iron to produce enough hemoglobin the body needs. Iron-poor diets can cause anemia in those with existing risk factors like CKD or ESRD. Blood loss via dialysis or frequent blood draws, as mentioned on the previous slide, is a reason for iron deficiency as you lose iron-rich blood. During infection, increased ferritin levels represent an important host defense mechanism that deprives bacterial growth of iron and protects immune cell function. In functional iron deficiency anemia, you will have a low iron saturation and elevated ferritin levels. Iron deficiency limits EPO responsiveness. And Giacomo is making sure that he gets plenty of iron-rich foods. Good job, Giacomo. Hemoglobin goal for ESRD patients. The goal range is set for 10 to 11 or 10 to 11.5 per KDOQI or KDIGO guidelines. For those of you who have not heard these acronyms, KDOQI, which stands for Kidney Dialysis Outcome Quality Initiatives, is a program of the National Kidney Foundation that developed and implements evidence-based clinical practice guidelines for kidney disease. KDIGO stands for Kidney Disease Improving Global Outcomes, is a global nonprofit organization that focuses on developing and implementing evidence-based guidelines for kidney disease. So a lot of times you'll see KDIGO or KDOQI referenced. So why are those goals so important? Hemoglobin variability above and below the goal is linked to higher likelihoods of hospitalization, also is associated with patient morbidity and mortality risk. Elevated hemoglobin is linked to vascular access thromboses, thromboembolic events, composite cardiovascular events, including non-fatal MI, strokes. Low hemoglobin is linked to fatigue, reduced physical performance, and quality of life, left ventricular dilation as well. So how do we treat anemia in ESRD? We replete deficiencies when they arise, including iron, B12, and folate. We start ESA therapy when indicated, and we transfuse with packed red cells when the hemoglobin is less than 7 or symptomatic. So that brings us to iron therapy. So the goal for ESRD is an iron sat of greater than 20% and ferritin about 10 to 300. If the iron saturation is less than 20 and the ferritin is less than 100 in the setting of a hemoglobin less than 10, then iron therapy is indicated in ESRD patients, and that's per a KDOQI guideline. Oral iron includes ferrous sulfate and ferrous gluconate, to name just a couple. And I wanted to point these two out because, as you can see, the tablet strength, 325 milligrams for each, yields different amounts of elemental iron. Recommended oral daily dose of iron is 150 to 200 milligrams of elemental iron per day. So you can see that you will get a larger dose of elemental iron taken ferrous sulfate at 1 tablet daily versus ferrous gluconate. Nursing administration points for oral iron. It's best if it's taken in between meals, but it can be given with meals if the patient is having GI upset. You also want to avoid taking with milk, caffeine, calcium supplements, antibiotics, or Parkinson's disease medications. Parental iron, such as Venofer, Ferlicet, and Injectifer, you may have heard, one or two of those names, can be given to patients on ESRD. Ferlicet actually is only FDA approved for patients on ESRD and not CKD patients. Venofer is often given via slow IV push for 2 to 5 minutes, and the other two can be given in a normal saline bag infused. The Ferlicet has to be infused fairly slowly. The Injectifer can infuse over 15 minutes. Nursing administration points for IV iron is you want to watch closely for anaphylaxis presenting as shock, hypotension, collapse, or changes in consciousness or loss of consciousness, and monitor for these symptoms during the infusion and 30 minutes following the infusion. Which brings us to ESA therapies that are typically started when iron stores are adequate and hemoglobin drops below 9 in CKD and 10 in ESRD. It's contraindicated in patients diagnosed with solid tumors, as ESA can increase risk for tumor progression. About 78.2% of hemodialysis patients receive ESA. And here's a list of some common ESAs: Aranesp, Epogen, Macera, which I believe is what we use at Whittier, and Procrit and Redicrit. I could be wrong, though. It could be Procrit. But I go to many places, so I do get confused as to which facility uses what. Nursing administration points for ESA. Avoid giving in patients with high uncontrolled blood pressures. Do not give if the hemoglobin is greater than 12, and typically avoided in patients that have recently suffered from de novo stroke, as Epogen can increase the risk of developing blood clots. Although there is not enough sufficient data on this topic, so it can differ between providers. It's exciting news that there are some new drugs emerging to treat anemia and ESRD, because for the longest time, patients have been dependent on the ESAs. These new drugs are called hypoxia-inducible factors. As you can see in this picture here, that this was a part of the anemia feedback loop. And these hypoxia-inducible factors enhance your body's natural response to low oxygen. They can raise blood cell levels and improve energy. And they also help your body use iron more efficiently, potentially reducing the need for iron supplements. I have 3 hypoxia-inducible factors listed here. Vadadustat, which was FDA approved since March of 24. Dabrdustat was FDA approved in 23, but then taken off the market last December for business reasons. I don't really know exactly what the business reasons were, but I wanted to list that to show that they weren't taken off the market for any adverse medical effects. And then roxadustat, which is not yet FDA approved. So yes, Giacomo is also very excited about these new anemia medications. And that brings us to blood transfusion guidelines. Guidelines do differ between facilities, so you want to make sure that you review your policy and procedure on blood transfusion and administration. I think it's important to know that leukoirradiated or leukocyte-poor RBCs are used in patients who are transplant candidates or recipients, or in those with prior febrile transfusion reactions. Washed or frozen packed red cells are indicated in individuals with hypersensitivity transfusion reactions. You can give blood faster during HD because the blood is being cleaned simultaneously, which reduces the risk of hyperkalemia by way of diffusion. And additionally, blood volume can be added to the fluid removal goal and taken off with HD by way of ultrafiltration. So that's definitely a huge perk to why we like to give ESRD patients' blood during dialysis. Nursing administration for packed red cells, you want to obtain baseline vitals, start blood transfusion at a slow rate for the first 15 minutes, and observe every 15 minutes. You want to monitor the vital signs and monitor for signs of transfusion reaction, fever, chills, flank pain, rash, itching, dyspnea, or changes in vital signs. If you do note a reaction, you want to stop the blood transfusion and infuse normal saline at KVO rate and inform the provider. This is just a table that compares trolley versus TACO. So trolley is a transfusion-related acute lung injury versus TACO, which is a transfusion-associated circulatory overload. And you can see here that TACO is more prevalent versus trolley, and that a lot of our dialysis patients will fall under being a risk factor for TACO. Age greater than 60, CKD, CHF, and high rate and or volume of transfusion. The pathophysiology behind TACO is fluid overload. And as you can see here down at the bottom, the treatment is going to be supportive and diureses, which, like I said, just gives us more reason why we would want to transfuse a dialysis patient during dialysis. So what are the challenges of maintaining hemoglobin goals? So biological hereditogeneity. Which is a variation in characteristics between cells, tissues, and organs, and a non-linear dose-response relationship, which is basically varying responses to ESA dosing, and time delays between hemoglobin measurement and dosing, which is basically the patient missing their treatments or missing planned time doses. And also a standard anemia protocol lacks interpretability of the underlying decision-making process. So there's this article that came out of CJASN. It's called The Effects of Individualized Anemia Therapy on Hemoglobin Stability. And it's a multi-center, double-arm, randomized controlled pilot study in patients on maintenance hemodialysis who were prescribed Mircera. And these patients were recruited from 5 Fresenius kidney care clinics in New York, New Haven, Connecticut, and Costa Mesa, California. And all of these dialysis clinics used what's called a crit line. It's a device that continually monitors hematocrit during dialysis. And the inclusion criteria for the study, the patient had to be equal to or greater than 18 years old, able to give informed consent on dialysis 3 days a week, receiving non-invasive monitoring of intradialytic hemocrit concentration during dialysis, which is the crit line that I had mentioned before, lab data at least 180 days from enrollment date, on average hemoglobin values available from at least 2 per week, either from the crit line or from laboratory hemoglobins during the past 180 days preceding enrollment. Also, renal anemia treated with ESA with at least 2 ESA dose administrations. Also on an active ESA anemia management algorithm as well. Exclusion criteria: if the patient was receiving max ESA doses consistently or hospitalized for more than 10 days, if they had severe iron deficiency, if they had any known cause of ESA resistance other than iron deficiency anemia or inflammatory states, any malignancies, hypersplenism, antibody-mediated pure red cell aplasia, simultaneous participation in another clinical study that may impact anemia management or outcomes of the trial, and inability to communicate in Spanish or English. So here's a quick little summary of the study populations, and you can see at the top that they started out with 556, and only 105 consented, 9 failed screening, which left 96 to be randomized. So in the intervention group, the outcome was 40, and in the standard of care group, the outcome was 41. So as you can see, between the 2 cohorts, it's pretty even, 40 and 41. So this schematic is the anemia therapy assisted system. And there's a lot to go into the explanation of the system, but I just wanted to point out some innovations of this anemia management method. And one of the innovations was that it combined a generic physiological-based mathematical model that described the physiology of erythropoiesis and RBC biology. The model was combined with a general ESA pharmacokinetic and pharmacodynamic model. An algorithm was used to individualize the model on a basis of the patient's routine clinical data, which was used to create a personalized digital twin or an avatar. That's really the part that I thought that was cool. A model predictive control theory was used to compute optimal ESA doses by stimulating the avatar's hemoglobin and determining a single ESA dose recommendation. So like I said, there's a lot that goes into explain this, but the fact that they created an avatar that was based off a real person's dose response relationship to erythropoietin was pretty cool. So I hope I'm not losing any of you, but it looks like I have already lost Giacomo, so I'm going to move it along, but hang in there because we're almost done. So this was the final summary slide on the study, the comparison between the anemia-assisted software and versus the standard population-based anemia treatment protocol used in Fresenius clinics. And as you can see, the conclusion was that the results demonstrated an improved hemoglobin target attainment and variability by employing personalized ESA recommendations using the physiology-based anemia therapy assisted program. So basically with the program, they were able to tighten up the hemoglobin responses to the ESA and avoid wide fluctuations. Additionally, they were able to attain the target, which was around 10.5, more consistently with the software versus the standard-based anemia treatment protocol. So that brings me to my questions and comments slide. So I'm going to open it up now to any questions if anyone has any.
Okay, and I can add the eval tool then for everybody,
You want me to
okay?
stop sharing?
I'm sorry?
Should I stop sharing?
No, you can share. Is this the conclusion of your talk then, Christina?
Yep, yep.
Okay, all right. So everybody that's with us, I am going to just do, you keep sharing. And of course, if there's any questions, feel free to answer them. Just give me a second to copy this.
Okay. I'm going to go to the chat.
So I just sent that to everybody and hopefully this does work. I did talk to IT guys. And if anybody does have any problems with this, of course, you can email me and I will send the eval tool link directly. Christina, can you see the chat line?
Oh yeah, for Maureen. What a fabulous presentation, great information, easy to understand your explanation. Thank you very much, Maureen. As I said, you know, I'm pretty nervous talking on these Zooms, and so that's why I incorporated my buddy Giacomo to kind of help me get through it. So I hope it wasn't too corny, but it worked for me.
Did a great job. Thank you so much. Thank you very, very much. And I'm hoping everybody can see this. Great. And you did very well. Yes, you did. I wholeheartedly agree. You did great. You did great. So that's the link for everybody. Are there any other questions or anything specific? I think everything's positive.
Thank you for feedback. All right. Well, if you guys see me walking around the halls at Whittier Rehab and you have questions on this or anything renal related, just pull me over. I'm more than happy to talk about anything. I love nephrology and I love my job. So I'll talk about this anytime.